Good day, everybody. Thank you so much. Welcome to the January 26th, 2022 edition of the Med Safety Exchange. We know that the weather has not been gentle, and we know that we're in another wave in the pandemic, and we know that most of us are all focused on providing clinical care, but we really do appreciate you joining us. My name is Mike Hamilton, and I'm Medical Director of ISMP Canada. This webinar is a production of ISMP Canada and the Canadian Medication Incident Reporting and Prevention System, CMIRPS, with contributions from all of our partners in medication safety and you, the audience. We host this webinar to encourage reporting, sharing, learning of medication incidents and medication safety topics. And we really do learn best from each other, and we really appreciate the generosity of our presenters in sharing their expertise and experience, and we appreciate your generosity in joining us. We hope that you can use this information presented in the webinar in your own organizations and in turn share your experience with others. We use the Zoom webinar platform, as you've noticed. A few reminders will help optimize your viewing and participation, ensure your computer audio is sufficiently loud, audience members are automatically muted, and your video is disabled. And the presentation part of this webinar is being recorded and will be available on our website in about 2 weeks or so. To submit questions, find the Zoom toolbar, which is typically at the bottom of your screen, although sometimes at the top. You'll find a number of options. Chat's disabled at this time. Raised hand is also disabled or ignored. If you do select the Q&A tool, a window is going to open up, and feel free to submit any questions via that tool. And you do have the option to submit anonymously. Your question or comment will go to the presenters, and they'll have an opportunity to respond to as many submissions as they can via the Q&A panel. Responses will appear in the same panel, and questions will only appear once they're answered. If we don't get to anything, or if you have further follow-up questions, please email us at medsafetyexchange@ismvcanada.ca. For today's overview, we are very pleased today to have some of the data experts at CIHI provide an overview of undertreatment incidents and some of the issues surrounding data quality related to undertreatment. And we'll follow up that with Health Canada highlighting some of the challenges with exactly how much mineral we are actually prescribing and actually getting when we take things like iron, zinc, calcium, and how best to convey this information. And we're also very pleased to welcome Healthcare Excellence Canada to the Med Safety Exchange. And for those who don't know, Healthcare Excellence Canada was formed from a merger between Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement, and is going to continue the great work of these two former organizations. We'll learn about their new strategic directions and some of their projects in medication safety. ISMP Canada, particularly the analysis team, works very, very closely with CIHI, and we're always very fortunate when they're able to join us and present. So I'll now turn it over to our colleagues at CIHI for their presentation. So I'll ask you to unmute and go right ahead.
Thank you very much. Today I'll be presenting some work we've done within the NSIR team at CIHI, specifically some work related to data quality and our incident review process. Some background on myself: I'm a pharmacist by training, so that influences how I interpret some of the data I'll be presenting. Next slide, please. So what is CIHI? CIHI stands for the Canadian Institute for Health Information. It is an independent, not-for-profit organization which provides essential information on Canada's health systems and on the health of Canadians. Next slide. And what is NSIR? NSIR stands for the National System for Incident Reporting. It is a voluntary and anonymous reporting system for both medication incidents as well as radiation treatment incidents. And the purpose of the system is to facilitate sharing and learning from these incidents when they do happen. As well, NSIR works very closely with our local and national partners, including ISMP Canada, to ensure that the data we gather yields recommendations and strategies to help reduce preventable patient harm. Next slide. This is a list of some partners that NSIR works with, including ISMB Canada and Healthcare Excellence Canada, as well as Health Canada. Next slide. And here are some high-level summary statistics on some of the data that NSIR holds. Again, if there's any questions about this following the presentation, just feel free to send us an email. Next slide, please. So moving on, the NSIR incident review is a process we undertake within our team, whereby for each incident submitted to NSIR, we are actually reviewing all of the text fields associated with those incidents. And there's two purposes to this process. The main purpose is to ensure that there's no identifiers present within those text fields. So anything like a patient's name, what provider was involved in an incident, what facility an incident came from. And the second purpose of this process is because we are already investing this time up front to review these incidents for identifiers. It's actually a great opportunity for us to also flag key incidents as we come across them. So incidents where we think they may offer potential value by being analyzed further or by being shared with our partners. So our hope is that by doing this, we can facilitate broader use of the NSIR data by our partners. Next slide. So this is an example of an incident which was flagged in this way within the incident review process. Don't worry if you can't read the whole thing, I'll highlight some key facts. Next slide, please. So a few key features of this medication incident. It involves a patient being treated for hepatitis C. This patient was being treated with a 12-week course of the brand name medication Mavorite. And in this case, the data submitter suspects that this patient may have received 1/3 of the prescribed treatment dose for this medication for a full week of treatment. So certainly a few key factors made this incident stand out within that incident review process. It involves a relatively uncommon medical condition. It involves a very expensive medication. And certainly reading the details as they are presented made me question what effect this underdosing could potentially have on this patient's treatment. Could this even potentially cause a treatment failure for this patient? So certainly I felt this was a noteworthy incident when I came across it, and one with a significant potential for harm to this patient. But at the same time, as you'll see kind of noted at the bottom, the data submitter in this case actually assigned this incident a degree of harm of no harm. Next slide, please. So this led us to this question. Essentially what we want to know are data submitters to NSIR potentially underrating degree of harm for these undertreatment medication incidents. So undertreatment meaning a patient has either not received prescribed doses of a medication or they've received less than the prescribed dose. So essentially what we want to know is this issue we're kind of seeing with this hepatitis C incident, where the data submitter has actually assigned it a very low degree of harm, but based on our own interpretation, perhaps there's a higher potential for harm. Is this disconnect kind of more widespread within the NSIR data? Next slide, please. So when we considered how to approach this question, certainly we want to look at this question both quantitatively, so looking at numbers and trends of incidents, as well as qualitatively, so looking at some of the narrative information within incidents. In the interest of time, I won't discuss how we kind of went about this quantitatively, but to summarize, when we looked at all of the incidents within NSIR, the different types and the different degrees of harm assigned to different types of incidents, what we found was incidents which could be considered under treatment in general did have lower degrees of harm assigned to them as compared to other incident types. So certainly that quantitative finding gave us enough information to want to look at this question qualitatively as well. Next slide, please. So when considering how to answer this question qualitatively, in an ideal world, we'd want to look at every undertreatment incident within NSIR, see the degree of harm as assigned by the data submitter, and kind of compare that to the degree of harm based on our own assessment to see if there's any disconnect between those two. But certainly that's not realistic to do with the number of incidents. So instead, what we selected to do was to look for specifically high-risk undertreatment incidents. And then for that subgroup, we want to assess the degree of harm based on our interpretation and see how that compared to the degree of harm as selected by the data submitters. So next slide, please. So this summarizes kind of that methodology I spoke to earlier. So again, we were looking for incidents in the middle, so incidents which are under treatment incidents and incidents which have a particularly high potential for harm. And then for that subgroup of incidents, we want to assess the degree of harm based on our own interpretation and see how that compares to the degree of harm as selected by the data submitter. Notably, when you're trying to find incidents with a high potential for harm, usually you could just sort your data by that degree of harm field. But because our question was kind of seeking to find how data submitters are using that degree of harm field and whether they're using it accurately, instead to find incidents with a higher potential for harm, we actually filtered the data by incidents involving some high alert medications. Next slide, please. So these are some examples of medications and drug classes we use to filter the data. Certainly we use more medications than those listed here, but these are to give you an idea. And these are drugs or drug classes where undertreatment, so missing one or several doses of a medication, has a particularly higher potential to cause harm to a patient. So for example, missing immunosuppressants poses a significant risk of complications after a transplant. Missing anticoagulants could put you at risk of clotting, etc. Next slide, please. So this displays how we kind of work the data down to a manageable number of incidents to look at. So at the top is our whole bucket of potential undertreatment incidents, so about 29,000 incidents. When we applied that filter of incidents involving some of those higher risk medications, that got us down to about 3,000 incidents. And of those 3,000 incidents, about 1,500 had text fields which we could look at. Our next step was to read those text fields and ask ourselves a few questions as we were doing that. One is what we're actually reading kind of indicative of an undertreatment incident. And if it is, does this incident have a high degree of harm or a high potential for harm based on our own interpretation? And if it does, how does our assessment of that incident's harm compare to the actual degree of harm that the data submitter selected for that incident? And then using that kind of process, we identified a few more examples we'd like to share. Next slide, please. We certainly came across many incidents like this. So in this case, a patient had a dose of hydromorphone scheduled for the evening. However, earlier in the day, their morning dose had been given late. So as a result, this evening dose was actually pushed to nighttime. But then at that time, the dose was missed. The data submitter in this case states that the patient did experience pain as a result of missing this dose, but they also state there was no harm to the patient, and they assign the incident a degree of harm of none. So certainly I think there's a little bit of a disconnect here. I think you could argue if the patient experienced unnecessary pain as a result of missing that dose of the opioid, that may constitute some level of harm to that patient. And that's something which could perhaps be captured in that degree of harm field. But as it stands, it wasn't. Next slide, please. And in this case, there was an order entry error with the patient's anti-HIV medications. So this patient was supposed to receive triple therapy composed of 2 different medications, the combination product brand name Truvada, as well as the single ingredient product with the brand name Tivicay. But in this case, the patient only received the Truvada. So in essence, they were only receiving 2 of the 3 prescribed antiretroviral medications. And at the end of the incident, the data submitter actually clearly articulates the problem in this case. So ongoing therapy with only one antiretroviral agent can lead to resistance. Yet at the same time, this incident was actually assigned a degree of harm of none. So this seems to illustrate what we're trying to get at, is that that degree of harm field doesn't always seem to capture the harm or the potential harm associated with certain undertreatment incidents. Next slide, please. So a few key findings. One is that based on this look at the NSIR data, submitters may be underrating degree of harm for undertreatment incidents, at least a subset of them. And when looking at the data, a few explanations come to mind. One is a failure to consider immediate harm as a result of undertreatment. So that kind of speaks to the opioid incident that we highlighted. And the second is a failure to consider potential future harm associated with undertreatment. So that would speak to the other 2 incidents, the hepatitis incident as well as the HIV incident. And then next slide. And the final point we'd like to emphasize is that filtering incidents by degree of harm in order to identify some key important incidents. Doing that may actually omit certain incidents which do have substantial analytic or shared learning potential. So really people who are looking at medication incidents are often using that degree of harm field as kind of a filter to identify key or important incidents, which they should kind of focus their time and effort on. And I think while filtering the data in this way will likely catch many important incidents, I think as we've shown here, using this method alone could actually omit some key incidents which are important and which we could learn a lot from. So I've outlined a few questions for your consideration on the slide. Do you use degree of harm in kind of a similar manner to the way I just described? So to find key incidents? And if you do, have you encountered a similar issue where there are important incidents which have been assigned kind of a lower degree of harm? And does that kind of risk those incidents being potentially overlooked? Thank you.
Thanks so much, Grant. Very important stuff. And we also often struggle with the attribution of harm, in particular because harm is a very common and natural way to stratify incidents. So if you're looking at very serious incidents, you may pick higher levels of harm. And as you've explained, you may end up overlooking a number of important sort of issues. So our key learning points that I'd like you to walk away with are instances of medication under treatment occur, and they should be recognized as potentially harmful medication errors. And analysts at CIHI have identified a risk of underreporting when attributing degree of harm to medication under treatment errors. So from your exercise, I'll sort of build upon the questions offered by CIHI. How do you or your organization recognize medication under treatment errors? Is there a systematic way maybe to identify these, such as a review of drug therapy levels, identification of suddenly escalated prescribed doses? And how do you determine attributable degree of harm to these types of incidents when in some cases you're looking into the future? Send us your thoughts, please, and certainly send them to CIHI. We'd love to hear of your ideas. So thank you very much for that presentation, Grant.
Thank you.
For our next presentation, I'll begin maybe with a bit of a confession that I myself prescribe mineral supplements, things like iron, like calcium. I find it really, really confusing when I write down an amount or write down a strength. Am I specifying the element itself or the salt? And what worries me is how is the person on the other end of this going to interpret it? How is the pharmacist going to interpret the dose? How is the patient, if they're self-selecting a problem, going to interpret this? For our next presentation, we're really delighted to welcome members from Health Canada who are going to review the issue, suggest some guidance and labeling that will help standardize the presentation and labeling of mineral supplements and really help us at least advance the safer dosing of these products. So thank you, and please unmute yourself and go right ahead.
My name is Anson Tang. I'll be presenting today with my colleague, Sally Pepper. We are both pharmacists and we work in the patient safety section of the Marketed Health Products Directorate at Health Canada. We are presenting on the topic of improving the labeling of mineral supplements. Over the last year, we have been reviewing medication errors involving mineral supplements, which have been reported to Health Canada. As a result of this work, we are developing new recommendations for manufacturers of mineral supplements to improve labeling and reduce confusion. Today, we're going to share some of these medication errors with you, along with recommendations for manufacturers. Next slide, please. So just to give a background for everyone, two terms which are helpful to know when viewing mineral supplements are element and salt. An element, or the active ingredient, is a pure chemical substance. A salt, or the source ingredient, is two or more elements that are chemically bonded together as part of a stable compound. For example, you'll see on the left-hand side the element calcium in red. This can come from actually more than one salt or source ingredient. So in the table we have on the right, it coming from the salt calcium carbonate, but it could also come from calcium citrate, etc. Nonetheless, the total quantity of element will always be less than the total quantity of the salt. So we see calcium 500 milligrams and the calcium carbonate 1300 milligrams. So in this case, to get 500 milligrams of the element calcium, one would have to take 1300 milligrams of the salt calcium carbonate. And we have some other examples in that table below. You'll see for iron, to get 27 milligrams of iron, one will need to take 81 milligrams of the salt ferrous fumarate. And for zinc element, 14 milligrams, to get that amount, we would have to take 100 milligrams of the salt zinc gluconate. Next slide, please. So here's an example of a medication error. This product was identified in a medication error involving a pediatric patient in a hospital. The healthcare professional then reported this error to Health Canada. On the left, you'll see that the label's principal display panel states zinc 50 milligrams. It's a little bit small, but on the right-hand side, the label's side panel, if you were able to zoom in, you would see that it states elemental zinc bracket gluconate 50 milligrams. So if you saw this product on the shelf, you might wonder, does this mean that the product contains elemental zinc 50 milligrams or zinc gluconate 50 milligrams? Next slide, please. Therefore, Health Canada recommends, as part of good labeling practices, that both the element and the salt with their corresponding strengths should be identified on the principal display panel, which is what you see in that graphic there. Strength should be located in close proximity to the corresponding name. So quantity of element near the element name, quantity of salts near the salt name. So ideally, the principal display panel for that zinc mineral supplement would be displayed as per this graphic example. You'll see that the 50 milligrams actually refers to the element zinc. And the strength of the salt, zinc gluconate, is actually 350 milligrams, which was not stated on the bottle's principal display panel, nor on its side panel. So you can see that there's a 7-fold difference in strength between the zinc and zinc gluconate. So for this actual error report, the pediatric patient was in hospital. She received an overdose amounting to 7 times the prescribed dose as a result of the confusing label on the bottle. Next slide, please. For our next example, here's a product that was identified in a medication error. This error was reported to Health Canada by a hospital pharmacist. On the left, you'll see that the principal display panel states calcium carbonate 500 milligrams. On the right, if you were able to zoom in, the side panel states on the first line, element calcium bracket carbonate 500 milligrams. In the next line, derived from 1,300 milligrams of calcium carbonate from oyster shells. So I'll repeat that. First line, element calcium bracket carbonate 500 milligrams, derived from 1,300 milligrams of calcium carbonate from oyster shells. So if you saw this product on the shelf, do you think the strength of the calcium carbonate is 500 milligrams or 1,300 milligrams? Next slide, please. Health Canada recommends, as part of good labeling practices, that the strength that appears on the principal display panel must correspond to the product name as listed and be placed in close proximity to that name. In other words, if the brand name is the salt name, then the strength must correspond to that of the salt. So for your information, in that image you had seen, calcium carbonate was actually the brand name. So ideally, the principal display panel for that calcium mineral supplement would be displayed as per this graphical example here, instead of calcium carbonate 500 milligrams on the bottle, which is actually incorrect. So the image had been calcium carbonate 500 milligrams, and it's the product actually contains 500 milligrams of elemental calcium. For this error, the pharmacist was dispensing 2.5 times the amount of calcium that the patient was supposed to be receiving. Next slide, please. For our final example, here's a multivitamin product that was identified in a medication error. A child had ingested this multivitamin, and this error was reported to Health Canada by a poison control center. On the left, you'll see that the principal display panel states Centrum prenatal. On the right, you'll see that the side panel states, if one were able to zoom in, iron bracket ferrous fumarate 27 milligrams. So if you saw this product on the shelf, how would you know if the 27 milligrams refers to the element of iron or the salt ferrous fumarate? Next slide, please. We would like to see the strength of both the element and the salt listed on the side panel. This graphical example is actually more relevant for single ingredient products. Here we see that elemental iron is 27 milligrams and ferrous fumarate is 81 milligrams. The strength is clearly associated with its corresponding name in this graphic. As we know, for multivitamins, it's not always possible to list both strengths of the element and of the salt due to the space limitations on the label. Other possible strategies for multivitamins could include placing ferrous fumarate on a separate line or adding words such as derived from ferrous fumarate. Next slide, please. We are creating and updating tools for manufacturers of vitamins and mineral supplements so that they can readily access the labeling recommendations and apply them to product labels. There's obviously a wide variety of products out in the market, and we need to allow for certain flexibilities in the labels to accommodate different types of products. In addition, we have some limitations with respect to what is required by regulations to be on the label. However, these new recommendations will help promote consistency in labeling and reduce misinterpretations that lead to dosing errors. We are also targeting manufacturers for which we have received reports of unclear labels and are requesting changes to those specific products, such as the calcium product that was presented earlier. Thanks very much for your attention, and we welcome any questions in the Q&A forum there. Thanks.
Thank you very much, and there have been a number of questions submitted. And thank you also for validating my confusion and reassuring me that I'm not alone. So for key learning points for this, certainly mineral supplement strength dosing information is conveyed in a multitude of ways and is really not standardized or understood. And Health Canada is providing labeling guidance that hopefully will reduce confusion and improve communication about strength and dosing. And for your exercises, or what we'd love you to think about, is to review the mineral supplements stocked in your organization. How many different ways is strength and dosing information communicated, and what errors might result from this? And how do you and your organization convey the strength, dosing, and mineral supplements? In particular, ask yourself if there's just differences between what the prescriber sees, if you use EMRs or CPOEs, for example, versus what the pharmacy sees, and what sort of errors might arise from that. And a number of these products are sort of self-selected by patients and consumers, and you can certainly understand their risk of making errors. So there has to be steps, I think, to help counsel them or help them understand as well. So thank you so much for that presentation. And we'll move on to our third group, and anyone in medication safety and patient safety all remember the great work of CPSI and CFHI in promoting medication safety. Healthcare Excellence Canada really, I'll say, incorporates the benefits of these two amalgamated organizations, and in a way that I think allowed for some renewal, some reinvigoration, and some refocus. And we're really thrilled to have them present and tell you more about themselves, about their current projects, and their plans for the future. By all means, go ahead.
Oh, thank you so much, Michael. Thank you, our colleagues at ISMP Canada and our other presenters. And I also want to take a moment to thank all of you who joined us today. We live in a pretty turbulent world. The virus and the pandemic has really changed our lives. And I also want to take a moment to recognize how impactful this was for healthcare workers, because we cannot talk about medication safety or patient safety without considering the safety of the people working in the healthcare system. So I just want you to know we see you, we hear you, we feel for you. And if there's any way we can help, just let us know. My name is Ioana Popescu. I am Director for the Safety Strategies and Programs at Healthcare Excellence Canada, and joining me is Joanne Sidorczyk, a Senior Program Lead, who will speak to you in just a moment. So Michael, can we go to the next slide, please? So this is just an overview of what we are planning to talk to you today, beginning with an overview of the strategic plan and diving in a few examples of our programs and partnerships. On the next slide, this is the purpose of this new organization, Healthcare Excellence Canada, formed just last year, so the name may be brand new to many of you on the line, formed through the amalgamation of the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement. The intent of this amalgamation is to do more together, to really be able to make concrete steps towards a future where everyone in Canada has safe and high quality healthcare. And medication safety is an essential component of that. On the next slide, we just wanted to illustrate how many people we talked to and consulted, and probably that included some of you on the line. So I just want to say a heartfelt thank you to all of you who helped shape the strategy, and I hope you will see yourself in it. On the next slide, you will see the high-level picture of our strategy. What we are trying to do over the next few years is the how, is where I want to focus on for right now. Continue to find and promote innovators and innovations. That includes best practices, and innovators includes the wonderful people like you on the line today. Where we have innovations and best practices and evidence to support that, help drive the adoption and spread of those good things across the healthcare system. At the same time, build capabilities that enable excellence across the healthcare system and catalyze policy change. So you will see both a good mix and combination of very tactical things, but also create an environment and a system where safe quality care can flourish. We have identified in our strategy 3 focus areas. They're quite narrow. So 1, care for older adults with health and social needs. Secondly, care closer to home and community with safe transition. And finally, pandemic recovery and resilience. I'm very curious to hear from you if those 3 focus areas resonate. And I'm even more interested to hear what are the medication issues or solutions that you experienced or noticed in those focus areas. If you can put that in the Q&A, it would be a lovely start for our conversation. As we work through our strategy, we'll include the perspectives of patients, healthcare workers, make sure that it adds value. The solutions and the programs we offer are culturally safe, promote culturally safe and equitable care, and includes the priorities of the First Nation, Inuit, and Métis people. Our values are probably not too different than the values of any other organization, but I just want to highlight the partnership value. And that's not new. On the next slide, we highlighted a few examples of our partnership. ISMP Canada has been, for the last 15, 20 years, a key partner with the legacy organization, and that will continue. We're working together on CMERPS, the Medication Safety Coalition, a variety of many other projects. We also worked with Health Canada on the labeling on non-prescription medication, together with Patients for Patient Safety Canada, which is a patient-led program of Healthcare Excellence Canada. Also worked with CIHI and many others. I don't want to bore you now with a list of many partners because there's a long list. I do want to highlight the Safe Virtual Care Project because it is an issue that all of us are confronted with since the pandemic came. Since 2021, Healthcare Excellence Canada has been working in partnership with Canada Health Infoway and others to identify and support the spread of best practices to support more people so they have safe, high quality virtual primary care. So that was the focus of the work that is still continuing. As part of that work, we identified medication safety as an important component. So we engaged with ISMP Canada to find out how we can advance medication safety in virtual care, in primary care, through transfer of learning from incident analysis, identify emerging issues, and develop evidence-based strategies to reduce the risk to patients. So we are excited to continue the partnership with many of you over the next few years as we roll out the strategy. And thank again all of the partners who have been part of our story so far. It's been a very good story, but there's so much still left to do. Changing gears a little bit, on the next slide, I want to share with you some emerging work that we're doing. And it's so linked with the presentation on degree of harm. We realized that we probably need to look at a more contemporary definition of patient safety and harm. So we are in the process of leading consultations with stakeholders from across the country to hear what they have to say about what should be in that definition of harm and safety. The society, the culture, the world we live in has changed. So we have to be in tune with that, but also look towards the future. What will we need over the next 5-10 years? So for safety definition, we are going to take the learnings from a framework launched in UK over 5 years ago called the Measurement and Monitoring of Safety. We've been pilot testing it in Canada with excellent results because it looks at an integrated view of safety that is about past, present, and the future. So bringing together the learning from has been care safe in the past. And again, we're using the word safe, not just harm, because there has been good care too that we need to learn from. Wonder and try to answer the question, will care be safe in the future? And also try to be proactive in the present to ensure that care is safe now. So there's a lot of work, tools, resources that will come your way to support this integrated view of safety after we define it. So I'm curious if this resonates with you. And on the issue of harm, so far we've been looking at physical harm as the main component of harm, but we have to look at psychological, cultural, financial, spiritual, any other, as well as the intersection about all those types of harm. So stay tuned for more information on this as we make our way to understanding what the current needs are, and would love to hear from you on those topics too. And now I'll turn you over to Joanne for the next few slides.
Hello, and you'll see on the next slide that we were recently approached by the Pennsylvania Patient Safety Authority and asked to include a report in their for their annual report on the Pan-Canadian patient safety. So this was a really daunting task that I had, where I worked with a number of our partners to collect an overview of patient safety indicators and incident reporting in Canada. And certainly we just submitted our draft to the Pennsylvania Patient Safety Authority, so stay tuned and keep an eye out for that actual report. What really stood out was the wonderful collaborations in Canada between ISMP, Healthcare Canada, CIHI, and Healthcare Excellence Canada, and many others, and how it's really not just one organization that can collect data, that we need to be sharing that data, learning from it, and making healthcare safer in Canada through this data. So it was really evident in this report that Canada is very strong in this. The report for Pennsylvania is actually going to be, there'll be 2 other countries included. So it was really nice to have the chance to highlight what is in our strengths in Canada. On the next slide, you'll see that the other piece that Healthcare Excellence Canada has been working on is that for 10 years, we've been publicly producing summaries of safety alerts. So some of these could be, for example, from ISMP, safemedicationerror.ca, and really around the world. So we have 19 different organizations that we track the safety alerts they put out. We summarize them both French and English, and we put them onto our database. So if you go to globalpatientsafetyalerts.com, you'll be able to search, which is a very a feature that many users really appreciate, that you could search by steroids, you could search by words such as falls, for example, and you'll get a summary of all the alerts that we have. So we have over 2,000 alerts in there. So you can take a look at that website for sure. And certainly on the next page, you'll just see that we're, these are the alerts, what they look like. So there's the ISMP alert, some from Korea, from the UK, Japan. And these are alerts that we get, and we use them and put them into a summary format. On the next slide, you'll see that we certainly do want to thank you for your time. I do want to echo Ioana's sentiment about please share with us. We really do want to hear from everybody here and from all of your colleagues. We need to know what's happening across Canada in a number of different environments and sectors, because it really does help inform the work that we do. So please, into the Q&A or on the next slide, you'll see our names, and email us, contact us, let us know, reach out to us in any way. We'd really love to hear from you. So thank you.
Thanks so much, both of you. Certainly a lot of work going on, and I'll just use this opportunity to pull out just a few learnings. Healthcare Excellence Canada, again, as you've mentioned, a new organization carrying on the work of CPSI and CFHI. And one of the things that I appreciate is the global patient safety alerts. It's really nice before even ISMP Canada comes forward with recommendations. We do search this. It's sort of part of our process, and it's available to anybody. It's really nicely summarized, and it is it's really the expertise and experience of experts, but also practitioners from around the world. So it's all there, easily digestible form. So as part of your exercise, when developing recommendations in response to incidents in your organization, really build in a process to review pertinent global patient safety alerts. And what this will do is really validate any approaches that you've come up, if someone else has brought those forward as well, but also going to give you some really terrific ideas or different approaches that maybe you haven't thought of that have had some degree of success elsewhere. And I do encourage you to spend some time on the Healthcare Excellence Canada website. And as you've heard, there are all types of opportunities for your input as they sort of develop their work programs, and a very engaged and listening organization. So thank you to both of you. And we do have time now to climb up into the observatory just for a quick update from our analysis team. Paxlovid, their nimatrevir 150 milligram tablets are the two pink ones, and ritonavir is 100 milligram, the white tablet there, is a product recently authorized by Health Canada to treat mild to moderate COVID-19 for certain clinical indications. It's really right now, I think, in limited supply, although things change quickly in these times. It's being distributed by the provinces and territories, some sending medications to hospitals, others sending them to community pharmacies. A number of initial safety issues have been raised with Paxlovid, including significant drug interactions, but also the packaging presentation of the product. These two medications, they're co-packaged purposefully because they need to be administered at the same time. A full single dose for an adult with normal renal function is 2 pink tablets and 1 white tablet. However, for patients with moderate renal dysfunction, the dose should be to 1 pink plus 1 white. And the company recommends that the extra pink tablet be removed during the dispensing process so the correct dose is provided to the nurse or patient. And in either of these cases, the recipient should be notified that the original package has been altered to provide the correct dose. And in either case, whether it's the 2 pink and 1 white or 1 pink and 1 white, the presentation is not a typical presentation for either patients or practitioners. So we do have some concerns and certainly some interest in how other organizations have been dealing with this. And another question that we do have as well is, in prescribing software and EMRs and CPOEs, how is this presented to the prescriber, and how is it presented to the pharmacist on the other side? Is there some alerts for the need for dose reduction and what it might look like, and how one is to modify the dose for the one component only? If you are preparing to or even have prescribed or dispensed some of these medications, please let us know what the steps you're taking to promote the safe use of this product. It's something that we sort of really should learn together about, and we'd love your feedback from the field. So please email us at ICMP Canada or put it in the Q&A and report your concerns through any of our reporting portals. So we heard from 3 very important partners today in medication safety, and I really want to thank them for the terrific learning shared today. It is a busy time, as we've mentioned numerous times, and we really appreciate everybody's efforts towards improving patient care. We also want to thank you again, the audience, for learning among us. Again, please let us know what you think by contacting us and completing the feedback poll. We're at the end of a new our season. Our new season will begin in May, so please let us know what you'd like to see that's different, or any changes you think would be made, or any topics you want covered. We do consider ourselves very fortunate to have presenters, particularly from smaller institutions or smaller organizations, share their expertise and experience. And we'd really love to count you among these people. Please email us or let us know about the safety initiatives that you have ongoing. We learn best from our colleagues, so please help contribute. Again, the link to this recording will be available on the Med Safety Exchange website in the coming weeks, along with some links to the websites and maybe some of the materials that we've discussed today. A PDF of the slides is also available upon request to the address listed here, Med Safety Exchange at ismpcanada.ca. And please, again, complete the poll. Our next webinar will be in May 2022. So please stay connected so that we can let everyone know when the date is finalized. And please keep an eye out in your email box for that. So again, I thank you. The presenters will hang around for the next few minutes for Q&A. And otherwise, please feel free to let us know via our email address. So thanks very much for attending. I hope you all enjoy the rest of your day.